Thank you. Good afternoon and welcome to today's meeting. My name is Abigail Marshall-Cutting and I chair the Adult Health and Active Lifestyle Scrutiny Board. At this point, I would like to clarify that whilst this meeting is being webcast live to enable public access, it is not being held as a public meeting in accordance with the Local Government Act of 1972. As such, it is a remote consultative meeting of the Adult Health and Active Lifestyle Scrutiny Board. The consultative status of today's meeting means that some of the usual formalities will not take place at the start of the meeting, and while it also means that the board will not be in a position to take any formal decisions, today's discussion will still very much help inform the work of the Scrutiny Board, and where necessary, any proposed actions that do require formal ratification will be referred to the next formal public meeting of the Scrutiny Board for approval. I would now like to invite members of the Scrutiny Board, including those who may be in attendance as a substitute member, to introduce themselves in the following alphabetical order. Councillor Anderson.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adel and Wharfdale Ward.
Thanks for coming. Dr. Beale.
Good afternoon. I'm John Beale. I chair Health Watch Leeds and I'm a co-opted member of this board.
Thank you, Doctor. Councillor Bentley, who's substituting for Councillor Hatbrook.
Good afternoon, Jonathan Bentley from Wheatwood Ward, and as the chair said, I'm substituting for Councillor Conrad Hartbrook.
Thank you, Councillor Bentley, for joining us. Councillor Cunningham.
Afternoon, everyone. Councillor Lou Cunningham from Armley Ward.
Thank you, Councillor, for joining us. Councillor Dowson.
Councillor Jane Dowson, Chapel Allerton Ward.
Thank you for joining us. Councillor Gibson.
Good afternoon, everyone. Councillor James Gibson, Crossgates and Winmore Ward.
Thank you, Councillor. Councillor Harrington.
Afternoon, everyone. Councillor Norma Harrington from Wetherby Ward.
Thanks, Councillor. Councillor Iqbal. Councillor Iqbal, are you there? Okay, Councillor Kidger.
Hello, Councillor Kidger, Wing Kidger, representing Morley South. Thank you.
Thank you, Councillor. Councillor Latty.
Good afternoon, Councillor Graham Latty. I represent Guiseley and Rawdon Ward.
Thank you, Councillor. Councillor Renshaw substituting for Councillor Taylor today.
Good afternoon, Councillor Karen Renshaw, representing Alton Robin Hood Ward.
Thank you for joining us. I would now like to, I believe Councillor Iqbal is back. So back to you, Councillor Iqbal. Could you kindly introduce yourself, please?
Yeah, Mohammed Iqbal, Councillor for Hunslet Riverside Ward. Sorry for the few minutes.
That's okay. Thank you, Councillor. I would now like to invite the officers supporting today's meeting to also introduce themselves at this point, and I'll start with our Principal Scrutiny Advisor.
Good afternoon, everybody. I'm Angela Brogden, the Principal Scrutiny Advisor to this board.
Thank you, Angela. And our Governance Officer.
Good afternoon, everybody. I'm Debbie Oldham and I'm the clerk today for the board. I am wearing a mask because my husband's isolating and we're in the same room.
That's okay, Debbie. Thank you very much. Okay, could I invite board members to declare any disclosable pecuniary or other interest? We got any? Okay. Agenda number 2, meeting note from the 27th of July 2021. Note of the Scrutiny Board's consultative meeting was held on the 27th of July 2021, and that has been provided for your information. So while this is not for formal approval, members will still have the opportunity to raise any matters in relation to that note. So I will ask, is anybody wanting to raise anything from the meeting of the 27th of July? Can you just nod your head? You're happy for me to just go ahead? Fabulous. Okay. Agenda number 3 is update on the development of the local integrated care system. So as referenced in the note from the board's meeting of the 27th of July, members had received a briefing from the Director of Adults and Health on the new Health and Care Bill 2021 to 2020 in context for health and social care in West Yorkshire and Leeds, particularly with regards to development of the local care integrated care system. Members agreed to maintain a watching brief in terms of the ongoing development of the local ICS, and so the board is to receive a further update at today's meeting, which will be in the form of a PowerPoint presentation that has been provided by NHS Leeds Clinical Commissioning Groups. I will now invite all participants to introduce themselves at this point. And I will start with, is Councillor Arif here now?
Yes, Chair, I'm here. Good afternoon, everybody. Good to see everyone. I'm Councillor Salma Arif, and I'm the Executive Member for Public Health and Active Lifestyles. Thank you.
Thank you, Councillor, for joining us. Councillor Jenkins.
Good afternoon. My name is Councillor David Jenkins, and I'm a Deputy Exec Member for Adult Social Care, Children's Services and Health Partnerships.
Thank you for joining us. We've got the Director for Public Health as well.
Afternoon, everyone. Victoria Eaton, Director of Public Health.
Thank you, Victoria, for joining us. We've also got the Deputy Director, Social Work and Social Care. She here?
Good afternoon, everybody. My name's Shona McFarlane, and I'm the Deputy Director for Adults Health. I'm also here for Cathroff this afternoon. Thank you.
Thanks for coming, Shona. We've got Tony Cook. Is he here?
Sorry, Chair, I don't think Tony's connected in yet, but he may join a bit later.
All right, that's fine. I definitely saw John.
Hello, I'm John Tatton. I'm Associate Director for Network Development for Leeds CCG in the partnership.
Excellent. Okay, so before we go into this, can I ask Councillor Arif or Jenkins, would you like to say anything first before we go into this?
No comments from me.
Okay, how about you, Councillor Jenkins?
Yeah, sadly, no comment from me either, but I'm happy to later.
Okay, so who starts?
I think it's me.
Is it you, John?
I think it is.
Over to you then.
Okay, Angela, have we got the slides? Okay, so as stated, we will run through some slides on the integrated care system and basically give you an update of where we are now. Okay, next slide. So summary of main changes. Over the next 6 months, CCGs will cease to exist by April 2022 and be replaced by integrated care systems. Integrated care systems really have 4 constituent parts. One is an integrated care partnership, which is a wide range of partners across the system who set the strategy for the ICS and maintain the focus on health inequalities and wider health systems. You've also got an integrated care board, which is the statutory arm of the ICS, which effectively takes care of making sure that we deliver all the national NHS priorities, along with making sure it aligns with the ICS strategy. At place level, we've got place-based partnerships. People may know that these were originally called integrated care partnerships, but because of the integrated care partnership, it's been renamed place-based partnership. These are generally coterminous with local authorities, not in all places, but within West Yorkshire. And based on the legislation, they can have different levels of delegation based on what's agreed with the ICS. And then on top of that, we've got more formally provider collaboratives. So these are sort of collaboratives between different providers across the ICS. So some of you may be familiar with WYAT, West Yorkshire Acute Trusts Collaborative. This is that sort of thing across the patch. You could include things like mental health collaboratives and community collaboratives, although the main one at the moment is the West Yorkshire Acute. It also allows for collaboratives at place between different sectors. Because of those collaboratives and because of the changes, the ICS signals a move away from the internal market. And one of the key things about this is it's not now just the CCGs that would be responsible in the ICS for population, but also providers within the systems. And therefore, decisions need to be taken jointly with providers and the ICS around making sure we look after our patients and public. Next slide, please. So West Yorkshire, this is a summary of where we are at the ICS level. So as stated in the last slide, there will be an integrated care partnership. That broadly is similar to what we have already, which is the ICS partnership boards, which sets the strategy for partnerships. We're then working through setting up the ICB rather, the Integrated Care Board. We've got a proposal, initial proposal around what that would look like in the membership, but the idea is that sits at the sort of ICS level, and the PCBs will be delegated responsibilities from that ICB board. The intention is to delegate all the budgets, so we'll be sitting in a similar place to we are now with the budgets and responsibilities to place. And instead of having the CCGs that are delegated responsibility, we'll now have a committee that includes partners, providers, VCS. We've established a set of governance principles and requirements, and building in independence and transparency across the system, and there's an outline of an IC constitution. There's a first draft at the ICB membership. It has people from third sector, it has people from providers, but that's going through a number of iterations, and that's out for consultation at the moment. I believe you've had a paper setting out progress today in the West Yorkshire ICS Partnership Board. Next slide, please. So this is just details of where we are in terms of timetable and the next steps. So the chair, the advert for the chair has gone out, and the intention is to, oh gosh, I forgot the word, to appoint a chair and chief exec September, early October. The chair interviews, the first panels for the chair are this week, and the interviews will take place next week. We don't anticipate will be an announcement for 2 or 3 weeks, because obviously they have to go up to the Secretary of State for approval. After that, the adverts are out for the chief exec. I think it closed on about the 27th of September, and interviews are expended so that we will have an appointment in October, mid-October. There's a range of things that are going on at the moment, like the development of the ICS constitution, the operating model, and working through the ICB membership. And over the next month or two, we'll be expected to have new iterations of those things. The intention is for all of these things to be in place so that we can start the ICP board in November and complete appointments to the ICB board between October and February. That'll be the other exec directors. Further iteration of constitutional post consultation by February. Next slide, please. Within Leeds, we've got a PBP development board in place. It's recognised that Leeds already works well as a partnership. So the only change that we're expecting in the next few months is that rather than the CCG, we have a place-based partnership board that will take responsibilities stated earlier for the budget that we have, which is 1.4 billion, and the delivery of the statutory duties associated with the health and wellbeing strategy. It's proposed that this board is a subcommittee of the ICB with full delegated responsibility for its members, and will mirror the ICB with independent members, so representation of NHS, Leeds City Council, public health, voluntary sector and ICB officers. And work is underway to develop a collaborative agreement to underpin this. Next slide, please. I think it's important to note that the place-based partnership isn't just the integrated care board or the Leeds. On this slide, it says Leeds Integrated Care Partnership. That's now place-based partnership committee. But the place-based partnership, it's all of those things within that diagram. And this just describes where things are new in blue and how they fit into the wider system as a whole. Next slide, please. And just a sort of update on the key next steps. Place-based partnership proposals, we've got a collaborative agreement being developed for the end of September for consultation. This will include the membership of the partnership board, how we're going to work, responsibilities and functions of that board, but that's obviously dependent on how the ICB and the sort of responsibilities are delegated, relationship with the existing Leeds partnership infrastructure, and relationship with the Leeds Health and Wellbeing Board Scrutiny. Although we've got a sort of populated board at the moment, we'll need to be making that more formal, so we'll be recruiting and populating to the PCB board and subcommittees by the end of October. And rather like the Integrated Care Board, we'll be operating shadow form from November onwards, with the final version following the consultation fully operational by April 22. And that's the end of the slides, if there's any questions.
Thank you very much, John. Okay, right, open to all of us now. For any questions or comments? Councillor Dowson, I knew her hands were going to go up first.
I did wait. I was hoping somebody else would come in, because I often think that my questions are so stupid and obvious that
No,
somebody
they're
else
not. No.
will know them already. And there were a couple of things. I was amazed at the budget, 1.4 billion. Is that right? And that's the LPB that actually has the determination on where that money's spent. But you also mentioned independence and transparency. Independent from whom? Because obviously the makeup of your board, if it's going to be independent, shouldn't have specific groups on there, and you would maybe want to encourage other people who hadn't thought about joining a board who are independent to come onto that board. So how's that going to be done, John, please?
I think we're still working through. I mean, there are VCSE, there are patient representatives on the current.
Sorry, VCS what?
So voluntary and community sector representation. So we have that on the current, what's called the Development Programme Board. And we've also got patient and public representation, but very, very, one person representing those. And it is quite challenging when you think of all the partners that are involved in that board, to make it manageable, but sort of be inclusive. And as I said, I don't think it's just one of the key things that I think is important here is it's not just that board that is the partnership. The partnership is wider than that and will link into other sort of forum around the system as well. So I forgot the first question.
Sorry, I keep looking for the raise your hand button, but obviously the first question was around the budget of the LPB, okay. Because you've mentioned there are other boards that people might be able to go on to and but the real decision-making body, I understand, correct me if I'm wrong, is the LPB, because I've been engaged with organisations where there's one main body that makes the decisions, and if you're lucky, if you're in various groups, you might be on one of the advisory bodies that sit on the side of that. So is that how this is going to work?
So to just go back to the 1.4 billion first, that's effectively the NHS budget at the moment for Leeds. So that's what the CCG would generally be managing within its own commissioning arrangements. That doesn't, so for example, Leeds Teaching Hospital has a similar size budget of 1.4 billion, but obviously that's money that comes in from services from outside of Leeds, if that makes sense, like specialist services and things like that.
So that's virtually ring fence then, John?
In sense of?
If it's coming in from other agencies into Leeds, it's probably coming for specific purposes?
Yes, it comes from other commissioners. So all I'm saying is that the total spend of health in Leeds may be different from that 1.4 billion because Leeds Teaching Hospital on its own has a similar budget to that 1.4 billion. So that 1.4 billion is purely what the CCG spends on its services at the moment. Doesn't include like social care budget or anything like that. And the place-based partnership board will effectively replace the decision-making around that money and nothing beyond that, if that makes sense. Oh, I've got somebody else on the screen.
Perfect sense, thank you.
And there are challenges around how that works at the moment, because obviously when you have a commissioner like a CCG, that effectively is the broker for the decision making that makes decisions for whether we invest in the teaching hospital, whether we invest in primary care, whether we invest in mental health. When you have all those partners on there, then we've got to have ways of looking at how they play into those decisions, because there'll be members of that board from Leeds Teaching Hospital, from the Mental Health Trust, from VCSE, from the voluntary community sector and primary care. So decision making is going to be more challenging about how we decide on where we invest the money.
If I can just come back for one final time, Chair. This is a really interesting question, isn't it? Because my mum used to say prevention is better than cure. And there's got this balance, isn't there, between dealing with the issues you've got now, but potentially looking maybe even not at the services that you provide. I mean, poor housing, for example, leads to lots of issues, mental health issues and health issues. Low educational attainment might actually result in or from the fact that young people aren't getting access to computers and so on. So it's looking at a city as a whole as opposed to an individual service is quite a difficult thing to do. And I sometimes wonder, when you talk about unwieldy bodies, how much we take notice of what is actually going on in the sort of real world. But it's just a conversation piece and not a question really for you, John. Sorry.
Yeah, I think.
Thank you very much, Councillor Dawson. I just need to take other questions, John, if that's all right, so that we work within time. Dr. Bill.
Thank you very much, Chair. Just a couple of points, which I have to say, I think in West Yorkshire and Harrogate are a vast improvement on the draft bill, which is currently before Parliament. And of course, it may be changed, it went its way through the committee and other structures within the Houses of Parliament. But firstly, as I understand it, and I'm sure John will correct me if I'm incorrect, first of all, there is the principle of subsidiarity. That is that decisions will be made at the most appropriate local level. And I think that is absolutely right. The other thing relates to the Place-Based Partnerships Committee, and two things on there. Although not a statutory requirement at that level, I understand that it is the intention the Director of Public Health will be a member of that committee. And again, I think that is right. I can't see how that committee can do its work properly if public health is not represented at the table. And secondly on that, I also understand, and again, please correct me if I'm wrong, that meeting will be in public. And I think that is very important that the public do have access to the deliberations that committee will be making.
So on subsidiarity, yes, you're absolutely right. The idea is that decisions are made at the lowest possible level that they can be made. In terms of membership and role, there's a paper that's come out Friday that's sort of new guidance, and it's on the NHS England website. I can share that with Angela later, that gives some sort of update, and that gives a sense of the expectations of people that will be on place-based partnership boards, which includes DPHs, members of voluntary community sector and others. So there are sort of gradually papers coming out that sort of make recommendations, although they're not, mandatory, about what is expected from those place-based partnerships and those local place-based arrangements, which does include DPH and does include others. So I'll share those with Angela, actually, the link.
Thank you, Chair.
Thank you very much. Okay. You can lower your hand now, Dr. Bill, except you've got a supplementary question. Okay, Councillor Latte, over to you.
Thank you, Madam Chairman. Just a couple of things. There's one point that I'm interested in, and that is that our GPs at the moment, the CCG sort of sets the tone for how they operate, if they operate or if they don't operate. Who is going to set that sort of tone in the future? And then I'm rather interested in the sort of public sector, and by public sector I mean local authority involvement in this. Looking through the list of who's going to be doing what, I can find under place perspective one local authority member, and then down under clinical and professional, the Director of Public Health. There are an awful lot of boards and different sort of bodies here, and two little spots where the local authority, and this is, let's face it, meant to be a much broader operation than it is now. Are we relying on the fact that we've got the Health and Wellbeing Board? Is that the local authority slice of the cake, so to speak, or have I got it wrong? Let me just make sure I have nothing else I wanted to ask. There's so much happening here, isn't it? But it's easy to forget what you were looking at. No, I think that covers it. Thank you.
So on primary care, I think that's an interesting one. I think that they will be on the partnership, place-based partnership board. It's not clear yet how.
Yeah.
Sorry?
When you say they will be on.
So there's a question about how much representation I will, when you see the guidance that's come on place-based arrangements, it does make suggestions that I can't remember what they're called, local care partnerships these days, or are members of that board. Now it suggests multiple on this in the document, but I don't know how they will engage on that specific board, whether they nominate or whether they work together to inform the working of that board, or whether there's a number of seats, but that's in that new recommendation. Now, one of the interesting things about this, about places, is what we have to recognise is within the ICSs nationally, our ICS is very big, and in many places, Leeds itself would be bigger than many ICSs. So the number of GPs, for example, and LHCs that we have in Leeds is far bigger than many of those other ICSs. So it makes it harder to gain that much representation in a place like Leeds. But that's the intention, that's in the guidance. In terms of local authority playing on, local authority are on the board, but the PBP, as we call it, which is hard to say. But the idea is that the PBP takes account of the national statutory requirements of the NHS, but also aligns itself to the Health and Wellbeing Board strategy. So it looks 2 or 3 ways in terms of what it's responsible for delivering in the place. So it does have an LCH person, it does have the DPH from the council on it, does have the Director of Adult Social Care on it at the moment in time, this moment in time, on the PBP. But it will look to other boards in line with that diagram earlier about how it pulls and links to other boards within the system.
Right, okay. So there was something that you said there that triggered something. Then you said something else, and I think I've lost it. I'll stick my hand up if it comes back. Thank you.
That's okay, Councillor Latty. Thank you. Victoria.
Thank you, Chair. I just wanted to comment really collectively on the issues that have been raised by Councillor Dowson, Dr. Beale and Councillor Latty, because I think they're absolutely the right issues that we need to be cited on and be kind of actively having debates on in the city. So the issue Councillor Dowson made around where's prevention in this and how does it join up to the work we want to do on improving health, not just delivering services. The connection with the Health and Wellbeing Board and this board and other boards is critical. And I think what is happening is that that board is broad and does include myself, Kath Roth and other colleagues, but we need to work through the fact that we are moving towards the board as a subcommittee of the NHS. I think that the reality is, it is a subcommittee of the NHS and makes decision on NHS resources. And the bit that we need to still do locally is build those partnerships so we can bring the whole of the system together and acknowledge particularly the role of elected members and the local authority in improving public health and delivering social care and children's services. So that's the bit that this group doesn't do and we have to build. So I would just support the comments that councillor colleagues have made and Dr. Beale, because this is the stuff that we do absolutely need to grapple with. Otherwise, we have a very narrow board that just looks at healthcare services. So thanks, Chair. I hope that's helpful.
Very helpful. Thank you very much. I believe Councillor Latty has remembered now.
Yes, the brains kicked in. Yes, Mr. Tatton, you mentioned the local care partnerships, and that is local care partnerships as we know them now, I presume, right, which are varied and operate in hugely different ways across the city, also have different lengths of tenure, etc. You're saying that there should be some input, or there will be input from them at some level, as a care partnership, local care partnership, or as individuals?
I think the guidance is suggesting at PCN level, so primary care networks, because as Victoria says, it is an NHS slightly focused place-based partnership board. So the expectation from the guidance is the primary care networks are playing into that board, as opposed to local care partnerships, which I know is a wider sort of, and maybe not aligned necessarily to PCNs always, primary care networks.
Local care partnerships are very, very local.
Yeah.
Yeah.
So this
surprised me if we found ourselves having a seat at the table. Yeah. Okay. Thank you very much.
Thank you very much, Councillor Lutty. Any more questions for John or comments? Right, John, do we know when these final proposals will be ready, if you don't mind, for consultation, so that we can gauge when we can have a proper update for everyone?
So I think the consultations are ongoing. I think the idea is over September and October, and it's all pending different guidance coming out, obviously, because things move a bit. Right. But I would say probably 3 months, 2 or 3 months before we really know where we are with some of the sort of consultation, like constitution. There's an operating model that's being put forward about how the board, the NHS board, effectively at the Integrated Care Board, links to PBP boards, our local boards. How does that work? And how do our staff align within that? So I think that's going to be two or 3 months before that sort of really bottoms out. Okay. So if it was coming back and you wanted sort of a better understanding, it would be October, November, because the other thing is that the first shadow boards of both the ICS and the place-based partnership are in November. Okay. So it might be that that's the good time to get a sense of where we are with some of those arrangements.
Okay, so we're looking at about November time.
Yeah, maybe November, December, depends, because they will have had their first board by
right. We'll be waiting to hear from you, and I take it you're leaving after this, is that right?
I'm going to the partnership board.
Excellent, okay, no problem.
I'll learn more there.
Thanks for coming, we truly appreciate it. Just before he goes, anyone have a question for John? All right, thanks, John, for coming, and have a lovely day.
Thank you.
Thank you. Okay, so we're moving on to the next agenda, and that's for same-day response services in Leeds. And I believe the guests that we have on there who haven't introduced themselves, do we have Kirsty with us here?
Yeah, I'm here. Hello.
Could you introduce yourself, please?
Yeah, certainly. So I'm Kirsty Turner. I'm Associate Director for Primary Care at the Leeds Clinical Commissioning Group. I've also got a colleague Gaynor here as well. Sorry.
Hi, thanks for coming, Gaynor.
Good afternoon, everybody. I'm Gaynor Connor, Director of Transformation for the Leeds GP Confederation.
Thank you for coming. Is Tony here now, or he's still on his way? Okay. So when we were considering priority areas of work for this forthcoming municipal year, the board had expressed an interest to understand how the COVID-19 pandemic has impacted same-day response services, including the effects of coming out of lockdown, and to consider the actions being taken to address such impacts. The NHS Leeds Clinical Commissioning Group has therefore led on providing a brief paper on this matter, which is provided within the agenda pack you all have got. So I will now invite Kirsty, except if Councillor Arif or Jenkins want to say anything before Kirsty comes in.
No, Chair, nothing from me.
Okay, Councillor Jenkins?
And nothing from me. Thank you.
Thank you. Over to you, Kirsty.
Thank you. I'm not proposing I read out the paper, so I was just going to do a little bit of an overview in the hope that you've all had a chance to kind of read and digest the paper that's been circulated. What the paper aims to do is kind of cover the background. What do we mean by same-day services? The current pressures being faced in some of our urgent and emergency care services. Similar overview of the primary care provision at the moment, and then really focus on some of those short-term actions to try and address that the current demand, but also setting that within the context of our longer term ambitions and I suppose aspirations for redesigning same day response services, regardless of what's been happening around the COVID-19 pandemic. Obviously, and rereading the paper, I suppose just a little bit of an apology because really do recognise the use of acronyms in that. So apologies if there are acronyms that we've not necessarily articulated what they are. But same day response obviously covers a number of services. It covers our emergency departments, Nhs, which encompasses both 999 and 111. There's our urgent treatment centres within Leeds, walk-in centres, obviously same day response services provided by our mental health services, our primary care providers such as GPs, dentists, our community pharmacies, and then extended access services as well. Obviously, it goes without saying the significant impact the pandemic has had on how patients access services and obviously how services are therefore delivered in response to the pandemic. I suppose significantly was the move to remote triage to try and prevent onward transmission. So where possible, encouraging patients to talk before you walk, that kind of scenario to ensure that any patients displaying symptoms could be managed appropriately without risk of onward transmission. That meant the use of triage and assessment services has increased over that time. And obviously some of the data we've shown throughout the different services shows the pre-pandemic period during certainly the kind of height during 2020, and then the significant shift that's happened as we've gone into 2021, and the increased demand that we have seen, particularly certainly from a primary care point of view, significant sharp increases around March 2021. I suppose key points to point out are the increases that have been seen certainly in A&E or our emergency departments, a 17% increase in major presentations, a 10% increase in minor presentations, obviously a significant increase as well in 999 calls. From a primary care point of view, again, some of the growth of appointments, particularly that shift in how appointments are delivered. So a significant change in the use of telephone appointments and a shift in face-to-face as well, which obviously during 2020 we saw a significant reduction, but we've seen those increases over the last couple of months, both from a total appointment delivery, but also that increase in face-to-face appointments as well. Through our kind of command and control systems that have been established, City Silver or stabilisation and reset have been focused on delivering the same day response plan, particularly focused on those immediate actions that we need to put in place to address the growth in demand at the moment. So the paper talks through some of those solutions and actions that are being undertaken to try and address that demand. So, for example, looking at increasing capacity from both an A&E point of view, a primary care point of view. So increasing the minor illness provision to try and stream patients away from emergency departments. Also, again, really trying to increase the use of other services. So the community pharmacy consultation service is a good example of a service that we need to roll out rapidly. Again, really trying to think about that left shift around what minor illness activity that might be going through to general practice that could be shifted into community pharmacy, and therefore keep seeing that left shift and supported self-care as well for patients. The short-term actions are obviously set out in the paper, but that is set within the context of that longer-term plan of wanting to transform same-day services for patients that will help to address that that kind of increase in demand, that increased use of assessment services. So we talk about 111 as a route of direct booking into specific services. So again, that concept of patients seeking advice before choosing a particular service, and the ability for 111 to direct book into those patients, with the overall aim that patients do get to the right place at the right time, ideally first time as well. I think, you know, we recognise that there is confusion for patients sometimes in terms of knowing which is the right service. So we've got to support patients to make that choice, but also, make it as easy as possible for them as well. You know, I think it goes without saying some of the challenges that we need to recognise. Specifically thinking about workforce, and that's not a short-term fix that we can put workforce in place tomorrow. It's also got to set within that wider strategy of increasing our longer-term plans for workforce development. So particularly with primary care, the plans of increasing the diversity of the workforce in terms of the number of roles and different roles, and again supporting patients to understand that if you see a physio, that's positive if that's right for your condition, as opposed to a GP doesn't have to see you for everything. And I know that you know, patients feel that connection to their GP, but it's about diversifying those workforce roles as well. And I suppose just recognising that the whole of our workforce, and I know this will be echoed across many staff groups, just in terms of the impact of staff absenteeism just due to COVID, the isolation issues, but also just people feeling fatigued at the moment just because of how demanding services are, and similarly how we support patients as well in their frustration if they're having difficulties in accessing care as well. So I just think it's right that we acknowledge some of those challenges that we know our patients and our workforce are feeling at the moment. I shall pause there for any questions.
Okay, thank you very much, Kirsty. Yeah, Lou Cunningham has got her hands up.
Thank you, Jen. Thank you, Kirsty. I'm just thinking, from my own experience of residents' feedback in my ward of Armley at the moment, I'm just wondering how much data we have on people who have been looking to book a standard future appointment that haven't been able to, that have then become a person that needs that same day response or an urgent response. So that I'm thinking of that in terms of general medical conditions, which they may just want to book a forward appointment, but they haven't been able to. Also, particularly in areas of dental health, that I'm seeing more and more often people are struggling to get appointments. Thank you.
Thank you. We're trying to look at that data around what's the change in waiting times. And I suppose one of the developments that we've got around our longer term plan is what does it look like? So we know the pandemic shifted to a total triage, but actually what we need to start introducing is that ability to pre-book, because I think, yes, the risk is that you can't pre-book potentially, and then something happens and it does turn into a more of an acute need. So I think that's the work that we need to do with our, our GP colleagues, our practice colleagues, to really see what that balance is, and going back to ability for pre-booking. So I definitely think it's something that we need to address, definitely. We understand that there is data available that will help identify that difference in waiting times. I just, at the moment, I don't have that, but it's something, I'm happy to come back with.
Okay, thank you very much.
Thank you.
Councillor Bentley.
Thanks, Chair. I really want to pursue the question that Lou has just raised, which is about waiting times for dentists, particularly. During COVID, people were either unable or reluctant to go to a dentist for obvious reasons. And presumably there's now been sort of a backlog built up, whereas what would have been routine appointments perhaps becoming more acute. And I'm particularly concerned about pediatric dentistry, the number of young children who are not being able to get access to dentists. And I just wonder if you have any comment on that, please.
I don't, unfortunately. So linking back to John's presentation, in the delegation of functions, NHS dentistry still sits with NHS England. So again, I'm happy to work with colleagues to get a position around, waiting times for dentistry. Apologies, I forgot to answer that in the previous questions. But so yeah, I don't have those details, but again, happy to explore that a bit further with NHS England colleagues.
And Kirsty, how soon do you think we can get this information? Because he has been asked a few times.
Right. It's not come via me, so apologies. I don't know who you've asked previously, but I'll pick up a call with the dentistry lead at NHS England this afternoon to see what data is available.
Okay, thanks. Dr. Beale.
Yes, thanks, Chair. First of all, Health Watch Leeds has been doing a study looking at the difficulty that the patients have been receiving and getting immediate care. It's currently in draft. I'm sure that will be being sent to the CCG, but I would be very happy also to make sure that it comes to this board as well, which outlines some of the issues and feedback from patients. If I can just pick up a few of those. First of all, the lack of clarity about what the options are. I mean, Kirsty said it includes and then gave us a list. And, if you ask whoever out there, they don't know what is available and they don't know which is the most appropriate one for their particular need. So I think there is a need to provide information, and maybe 111 first, actually contacting 111 and getting some information on what is appropriate for them with their particular issue. I don't know, but that might be the way forward. Secondly, there have been a number of cases where GP has not been available or not offered a face-to-face appointment for patients who really feel they need a face-to-face appointment. They are not happy about digital, whether it's by phone or video, and end up going to the emergency departments of the hospital, A&E, for case situations which aren't really appropriate for the emergency departments. Thirdly, some cases of GP receptionists who've been carrying out a triage for the practice and then sending the patients to the hospital emergency department in spite of the fact that it's not a situation which does require urgent treatment and should be suitable for a GP. The fourth thing was the dentistry issue, and just to say, Kirsty, West Yorkshire and Harrogate have currently had a working group looking at the issue across the whole of this region. I was on that working group, and there is a sort of draft report coming out there. And I'm sure Emma Wilson will have access to that. So it would be useful to find out, because not only are people not able to get NHS dental care, but also some of the urgent care being carried out is not clinically not appropriate. Patients are being prescribed antibiotics for abscesses. It's not an appropriate treatment. It might depress the infection very briefly. It doesn't get rid of the problem, comes back. They go to usually another dentist that they're referred to, get another course of antibiotic. It's not appropriate treatment, and it contravenes the guidance on inappropriate use of antibiotics as well. And just one other particular question in the paper which we had, looking at the future, it talks about expanding the number of GPs. Well, I wish. We know the government have increased the number of medical students. It takes a long time before they come out as GPs, but you have to offset that against the existing GPs are going to be retiring. And if you look at the age cohort, quite a lot of our GPs in Leeds are going to be retiring in the next few years. There is, I understand, a move towards increasing early retirements. So age doesn't always dictate when people are going to retire. And GPs who basically are stressed out and go part-time rather than working full-time. So I just wonder how realistic it is to be talking about increasing the number of GPs.
Thank you very much, Dr. Bill. Kirsty, do you want to come back?
Yeah, I mean, I suppose just in terms of your first points around the work that Health Watch are doing, I suppose just to say I'd really welcome the report and how as a partnership we can work together on that. Certainly as part of our business as usual quality processes, we keep a handle on all of the patient experience, NHS choices, or reviews where people we keep a handle on those kind of comments and try and address those in a reactive way. But I think where we've got that ability to have a report and that feedback and how that can help influence future decisions, I think the more we can do that the better, and use the information that's already there. I think where there's those examples where things don't seem quite right, I think as a team, again, through our business as usual quality process, we're happy to pick those up. So the examples about, receptionists inappropriately signposting, if that's the case, we'd always want to explore those further. So I suppose that's just to reiterate, we're happy to receive that feedback and address it. I think your point about workforce, I suppose I recognise, which is why we've got to some of the short-term actions and the longer-term actions, and actually the workforce is a particular work programme in its own right, and why we've got to look at all of those recruitment, retention initiatives, but also the totality of the workforce as well, because it's not just GPs that do make up the primary care team, it is a team ability, and I think we've got to think differently about how we do, what does the workforce of the future look like, but yeah, I don't have a magic wand to say yes, we're going to have those 6,000 and they're all going to be in Leeds, for example, but actually we've got a part to play in that, along with all the other agencies as well that exist in terms of the universities, the medical placements, etc. So yeah, I suppose I recognise and hear what you're saying, definitely, and it's part of our longer term strategy that sits apart from the same day response, but it obviously contributes to how patients do have a positive experience of care.
Okay, thank you very much, Kirsty. Dr. Bill, have you got any supplementary questions to her response, or are you okay?
I'm fine, thank you, Chair.
Thank you. Councillor Harrington.
Thank you, Chair. Kirsty, there's a couple of things really. Touching on what Dr. Beale's just said, do we know how many vacancies there are for GPs across Leeds? Because that might be quite shocking for people to see how many there are. And again, it's what plans are there to recruit over the next 3 to 5 years to replace retirement. So it's really quite worrying. We have 2 part-time doctors in one of our surgeries, and if one of those decides to leave, we are absolutely in a tragic situation, really. And the other question I have is that I was always under the impression there was supposed to be a designated GP, a named GP for all older patients. I don't know whether it's over 70 or 80, but my father's 95. He hasn't actually seen a GP for 3 years now, because he hasn't been called to be seen. So what are they doing about reintroducing that, who are, they've got patients who are chronic patients with long-term diseases, they're not being reviewed. Yes, they're having a pharmacy review of their drugs, and they sort of say to him, oh, are you feeling all right? Is that okay? Whatever. But they aren't actually being seen by a doctor. and them looking at the patient and him seeing the colour or the, you know, how the guy's presenting himself or anything else. So I'm really concerned about how we get that back, that GPs should be taking that forward as soon as they possibly can. And then the other thing really is about the team ethos, and I totally get the idea of having a team of operatives within a GP's practice that would deliver different things. But what communication are we actually giving as a local area about how those teams work, so that patients, when they're told, actually, your call is going to be what is triage, it's going to be triaged, and we'll decide what the best option is. And that may well then get away from this thing about needing a same day appointment, because if they understand, if they talk to the pharmacist at the practice, they don't need to see a GP for that. A lot of it is frustration on people's part, really, and I'm just quite concerned that there doesn't seem to be a lot of communication on that. Thank you.
I hope I remember all of these questions. So the provision of a named GP is still there within the contract. To use the example, at some point that named GP should have been given, and if, providing that's not changed, then that should still be in place. The provision within the contract about being seen within 3 years is very specific in that it's if a patient hasn't been seen by anybody. So if there has been a review of somebody, then there's not a specific need for a review necessarily. It would be if I think it was your father, if he'd not been seen in the last 3 years by anybody at all in the practice, then there would be an element of a review during that time. But if they have had their needs seen by something else, so I suppose it's a technical thing around the contract, but if they have had an interaction with somebody, then that constitutes as a review almost. I think your point about communication and are we communicating sufficiently, I think it's probably the right one, and I think it goes back to a point Dr. Beale made around I suppose the choice and how do we actually make sure patients know what the right service is. So I think that needs to form part of those actions really around how are we communicating that. And I suppose I'd expand that a bit more so that where it's not just about how, the use of triage, but it's about the different workforce roles that are within primary care now, and exactly your point that if you're having a review about a medication review within a pharmacist rather than a GP, then that's a positive thing because they're specialists in that area. So I think that's definitely an action that needs to sit as part of that bigger action plan. I think part of this was started around how the roles were changing in primary care pre-pandemic, and obviously it's got lost slightly because of the shift. Or because of the pandemic, because obviously it's taken resources elsewhere. I suppose the points that you're making about workforce, I just wonder if that's something that maybe we can come back or share, because there are plans in place. So I think you had a specific point around number of vacancies, and I don't have those figures to hand. However, we do know through the GP contracts and the expansion of the roles available that by the end of this year, there's an aspiration for an additional, I think it's something like 280 whole-time equivalents, but that's made up of pharmacists, social prescribers, dietitians. There's about 13 other roles that could be available. So I just wonder if that's something that we can come back with a particular focus on around primary care workforce roles and what that might look like between now and 2024, for example, so that I can give you the information that you've requested.
Thank you very much, Kirsty. Yeah, I will be interested in knowing the figures as well, especially in terms of the numbers of GP based on how many, in terms of the delays that we're receiving reports on people trying to get through to their GP. So that's very important. Norma, what I would like to ask is, obviously with your dad at 95 and has not been seen for 3 years, I take it he's been in very good health. So is that 3 years of, and that's a very good thing. That's really positive, I must say. So well done for that. Can I ask, 3 years, has he tried to see a GP and has not been able to get an appointment, or he's just been ignored completely?
Well, I do stuff because I've got lasting power of attorney for him. So because my dad can't speak, which makes things quite difficult too. But yeah, it's me that I will ring up and they'll triage basically via me. And then they'll say, oh, well, you just need to talk to the pharmacist about that. But there are some things that, yes, he would like to go, but you need to get him face to face with the person. And that has been difficult. So yeah, it's been, oh, well, we can't do it at the moment because of COVID and those kind of things. So, and I know that it'll get better. I know it will. But it was just to demonstrate the point that there must be an awful lot of older people who maybe are in worse health than my father is, who really, really are worried about the fact that they haven't seen anybody, and they may well be going with undiagnosed issues that are then going to become something quite urgent. That was all really.
Yeah.
Thank you.
Okay, Councillor Dowson.
Yeah, this is another one, I'm afraid, for you, Kirsty, and I know it isn't your field of expertise, but you have volunteered to go away and get some information. But we're back to dentistry, I'm afraid, and I'm concerned specifically around referrals to the dental hospital. Dentists are professionals. If they refer somebody to the dental hospital, you would assume that that is a case that needs to be seen by the dental hospital, and yet I'm getting reports back that those referrals have been turned away. And also the relationship between a person's doctor and their dentist, there doesn't seem to be one at all, and in some cases there does need to be that relationship because one will affect the other, and I'm just wondering, has this been a long-standing thing where doctors and dentists don't talk to each other, and if so, why, and can we get that corrected?
Yeah, it's a good question. And where's Dr. Beale gone? Because I wonder if he's better to answer the question around if it's a long-standing query. I'm happy to take it away and explore that with the NHS England in terms of the queries around referrals to the dental hospital. I think with, the changes that John's been talking around partnership dentists as providers, actually, I don't know where that conversation is around, where are they around the table anyway? And I think it is about how do we develop those provider relationships. I just don't think have been there in the past. So ever the optimist, it's how can we use the new infrastructure to try and facilitate that better understanding. I know the representative groups do meet together, so the medical committee, the dental committee, the pharmacy committee, which is a step in the right direction, but it's almost like how do we help facilitate some of that as well.
It would be nice to have the statistics, Kirsty, just how many people that have been referred by a professional to the dental hospital are subsequently getting turned away. That's a specific question, and I would like those figures, please. The rest, then obviously that'll come with time, but this is a very specific question for this particular time post-COVID. Thank you.
Thank you very much. Sorry, Kirsty, the dentistry question will not go away. So until we have answers, it will keep coming back. So it's very important that we get to the bottom of it. Thank you. Councillor Latty.
Thank you. Yes, it's nothing to do with dentistry at all. Just occurs to me that when I asked my questions earlier on about who was going to be controlling, in the nicest sense, the general practices of the city, and it would appear that what we're talking about now is the form of control. I just wonder whether there is going to be the opportunity for setting some new standards for general practice. This business that people, being a doctor was a vocation, and with a vocation, people regard that as a way of life, and doctors used to work all the hours that God sent. As you all know, I'm an incredibly old person. I remember doctors back in the days. I even do remember before the NHS started, but it's childhood memories. And doctors nowadays bear no relationship whatsoever in their way of practicing to those of earlier years. And I just wonder whether the time has come to say, look, you might have different rules to work by, but you've still got a hell of a lot of people to see, and you're not going to do it if you all go into this job intending to work 3 days a week, which, looking at my practice, or the practice that I support, that would appear to be the case. Then none of them work a full week. And of course, as we know, they don't work evenings and nights nowadays. They don't have to do house calls unless it's absolutely essential. So in lots of ways, it's a lousy job. But in lots of other ways, it's not as bad as it used to be. And I just wonder whether we might be able to address it through this new form of NHS management. Thank you.
Thank you, Councillor Letty. Back to you, Kirsty.
Yeah, I think I suppose general practice has changed significantly over the years, and the expectation from a sense of what the contract and let's be really honest about it, this is a nationally set contract that's nationally negotiated, so some of the expectations on them is nationally set, which is difficult for us to control, as you put it. I think where we do have the opportunity is on our local commissioning. So actually, how do we, and the shift with the ICS event, again, linking it back to what John was talking about, is about population. So how do we utilise our local commissioning flexibility that we might have to set us on that direction? So I hear what you're saying around it's not quite right now, and how do we therefore use our influence and what the delegation that we might get from the ICS. It's how we use that so that patients have a better experience. I suppose just in defence of general practice and primary care, the expectation around the level of service that they provide is far greater than it was. I've done this for 25 years now. We've got to think about the safety and quality of service that is now expected. We've got CQC requirements, etc. So the days of being able to operate a general practice out of your front room and still doing the house calls, at midnight, it's not there. And again, that's not necessarily the GP's choice. It's because, again, the contract was changed so that out of hours was delivered in a very safe and measured way in terms of the callback provision, etc. So I do hear what you're saying around it's not perfect and patients are struggling, and I think it is about how we use our local commissioning through the ICS going forward. But at the same time, I think we've also got to reflect around the level of service that is available now in our practices and how that has also changed.
If the level of service was acceptable, we wouldn't be having this conversation. And not just me, but several people have been saying it. But I do take your point. But then again, go back to my practice, there are about 9 doctors there. The chance of seeing the same one twice on the trot is about the same as going to Mars. So I just leave you with that thought. But thank you.
Yeah, no, and I know the issue, but again, I think the positives of GPs working part-time means they also have interest in other areas, which also then heightens it brings some specialism potentially to their practice as well, which benefits their patients. So again, I hear what you're saying, but I think we've also got to recognise that the workforce is looking at wanting to have portfolio careers and have interest in other areas as well. I think, again, recognising the pressures that practices are under our individuals, actually having that ability to have a varied career and work-life balance as well means that people will stay longer as well. So yeah, I think it's how we get the balance right, isn't it, between patients having a good experience. Yeah, I'll stop.
Thank you, Kirsty. Councillor Renshaw.
Thank you, Chair. It's just really following on from Councillor Latter's comments there, but obviously this was in mind before. Have you got any figures that can tell us what the general turnover is on a GP practice of doctors? Because I know at my local surgery, there's been a real changeover of GPs, and like what's already been mentioned, you can't guarantee you'll see the same one following on, and that's under normal circumstances, not during the pandemic. And then you'll go see one that's part-time, and if you want to see the designated GP, you may have to wait up to a period of about 3 weeks before you can get an appointment with that specific doctor. It's only if you say, I'll see anybody because I'm ill, that you will manage to get an appointment on that day. And I just wondered if that was generally throughout all practices, or whether it was just specific ones in our city that have that sort of service. And even during the pandemic, the surgery's been okay for nurses to use, but yet you couldn't have a face-to-face appointment with a GP. And I just wondered if there was some explanation as to why that was happening and why a GP couldn't see you, but a nurse could. And a nurse could come to visit, but a GP couldn't.
So I'll take the first query first, which was about turnover. So I think that's linked to the wider workforce that we've discussed. So I don't have those figures to hand. So that's something we can explore. I suppose we need to be really clear. Face-to-face appointments have been available throughout the whole of the pandemic, and some routine services. So throughout, the whole of 2020, you might not have been able to see a nurse because certainly a lot of routine services were stopped during part of that time. I think the difference between nursing services and GP services are a lot of nursing services you do have to do face-to-face, and there isn't a remote way that you can do a smear test, for example. You absolutely need to be face-to-face. Similarly, vaccinations. However, nurses were doing some long-term condition reviews, over telephone or through remote functions, and would have only done part of that at certain times during the pandemic, a remote only, and then you might be invited face-to-face when services were reopened. I suppose from a GP point of view, it was always about, and so sorry, just to go back, even for those nursing services, there would have been an element of pre-screening first to make sure that you weren't, having any symptoms that could have been COVID, for example. And that's ultimately what the remote triage was for GPs. It was, are we screening you to make sure that you don't have COVID, or is it something that could be managed over the phone to prevent that need to be seen? And again, part of the rationale for that is we've seen a spike in demand, and actually the ability to see more patients almost with that mix of pre-screening and triage first, and then inviting those people who do need to be seen back, just means that people are waiting for less time. I think we've got to set it in that context around, we have seen, a peak in demand that needed to be addressed. And if everybody had just been seen face to face, then we would have been dealing with even more, longer waits as well. Again, I think I've said earlier, I think we need to get a balance right, and the ability to pre-book where it's obvious you do need a face to face. But actually, there hasn't ever been a time when face-to-face hasn't been available. It's always been there if patients did need to be seen. So I just think it's important that we reiterate that.
Yeah, can I just come back, Chair? Because I don't think that's been happening throughout the city. And I think some patients that I've spoken to in my ward have found it rather difficult to explain over the phone what exactly was wrong with them, because they couldn't use the body language to express or show the doctor. They might have been showing the doctor, but he couldn't see, or she couldn't see, where they were pointing to on their own bodies because of the language being used, and they found it difficult to express.
Yeah.
So I just think that's something we maybe need to take into account going forward.
No, I agree. I'm really sorry as well. You've just triggered another. I think the issue you raised as well about specific doctors wanting to be seen. I think there's always a favourite, if we're being completely honest, within specific practices where, you know, all patients might want to see that individual, and I think that's been kind of the nut that's always been hard to crack, almost around how do you balance that patient wishes to see a specific GP versus needed to be seen, and I think those kind of favourite GPs, there's always a long list that I'm not sure, apart from trying to clone them, I'm not sure. Yeah,
I'd just be interested in the turnover of staff, because I know that some GPs, you get a letter saying which GP you're designated to, but before you have a chance to even meet them, they've moved on. And I'm just wondering if there's some sort of unrest among doctors themselves, among GPs, that's creating this huge turnover of staff.
Yeah, I mean, sometimes I mean, I'm happy to pick this up separately if there's specific practice, because sometimes if they're training practices, whilst you might not, do you know what I mean? It could be that they're moving on through their training program. So you do see that turnover within some specific practices, but it's actually because they're part of that training bit. So, but yeah, if there are specific concerns about, you know, particular practices, then I'm happy to pick up outside and have a conversation, definitely.
Thank you.
Thank you very much, Kirsty. Okay, Dr. Bill.
If I might just come back on the issue of dentists talking to doctors, because this is something which I've supported for the whole of my life, basically. So it brings joy to my heart that that's being mentioned. But relating back to the last item on the agenda, or the one before last, in the health and care bill, it does, hidden away in the small print somewhere, talk about the primary care networks, including dentists, pharmacists and opticians. And I have raised that with our local British Dental Association committee for West Yorkshire that I'm a member of. And we have a new chair of the Leeds local dental committee, who I didn't know before, but I've had one telephone conversation with him, and it is on my list of things to raise with him, because I think it's going to be very important that dentists play a part in the PCNs, the primary care networks. There is the issue of, you know, if they're out of the surgery, they're not getting paid, but it's not beyond the wit of the system to be able to make arrangements to provide some finance that they can do that. So I think that is a good point that we need to make sure is not dropped out of the health and care bill as it goes through Parliament.
Definitely, Dr. Bill. Thank you very much. Kirsty, there are a few questions that need answering from this agenda. So myself and our principal scrutiny advisor will work with you, if that's okay, and try as much as we can to get all the answers, of which we will now bring back to the board, because sometimes some of the answers we receive will trigger more questions. So we would need to now arrange for another time to bring back all the responses that we will get from yourselves back to the board. Is everyone okay with that? Because I do believe Kirsty has got a good number of things that she needs to come back to us from what we have just discussed. Is that okay with everyone? Just give me a thumbs up so that I know you're not sleeping. Excellent. Thank you very much. Over to you, Councillor Jenkins.
Yes, I just wanted to ask a question really about Urgent Care Treatment Centre in East Leeds. It noticed in the report that there's been a 2% increase in urgent care treatment centre use in Wharfdale and St George's maybe, but we're still waiting after 3 years, I think, for a decision to be made about where the urgent care treatment centre would be in East Leeds, which may take some of the ways in which people can get access be more broadened, if you like. And the other point is that I asked if Gaynor could attend from the GP Confederation, and she may be able to answer some of the questions that have been raised.
All right, Councillor Jenkins, that specific question for Gaynor then? Is that what you're saying? Yes or no?
I'm happy to take the urgent treatment centre, and then I'm sure Gaynor might want to just come back about some of the previous questions that have been raised from the Confed. Is that fair, Gaynor? In terms of the urgent treatment centre, you're absolutely right. And I suppose during the pandemic, the work on that development of new urgent treatment centres for the city was on hold. That's absolutely part of those longer term strategies that we want to get back up and running. So absolutely, that's part of the next bit of work, which is what's the future direction for urgent treatment centres now? What's the data telling us? Have patient behaviours changed? You know, is East Leeds the right place? So we just need to refresh all of that. So absolutely, we'll come back out to I know through the work that we're doing around East Leeds extension and future provisions that we'll be picking up those conversations as well. So it's absolutely on our radar. So just to give you that assurance, I'll hand over to Gaynor just to see if she wants to sum up now.
Thanks, Kirsty, and yeah, thanks, Councillor Jenkins, for asking me to comment. I think it's clear, isn't it, that we've still got a big gap between people's experience of being able to access the care that they need versus some of the things that we feel are being developed and put into place in the system to address some of it. So, for example, as Kirsty's described, that big expansion of the workforce within primary care, through one lens, we can describe that in a really positive way and a really rational way that says, you know, going back to some of the things that we've heard about in terms of the shortage of GPs nationally, the retirement age of GPs nationally and locally, that actually it makes sense to introduce a more diverse workforce that might have needs that mean that, you know, the old model of somebody seeing a GP and then being referred to another actually can be streamlined and made much more simple, which is that person accesses the another who is more of a specialist in their field first time. And actually that's much more efficient and a much more should lead to a much better experience and a much better outcome. But unless we describe that properly to the public, the people don't understand that actually that's a better offer and there's a real sound rationale behind it, which is about the right person seeing you at the right time with the right condition. Plus also it does address the issue of, like I say, we're not getting the numbers coming into GP training that maybe the government would, puts out that the targets in terms of increasing the number of GPs. But unless we get medical students that wish to go down that line, then we're never going to recruit the numbers. I think the business model for general practice that we've heard about before in terms of, GPs becoming partners in a business, that's not necessarily attractive to younger doctors entering GP training and entering the GP, general practice arena. So I think these problems are historical, are multifactorial, and represent, lots of changes that have been happening over a number of years, which have perhaps been exacerbated during the pandemic. So, for example, the introduction of new people in the workforce and the introduction of more virtual ways of consulting with patients are leading to and now obviously the backlog in terms of the impacts of the pandemic, leading to a bit of a perfect storm, which we know is happening nationally and we see and hear reported locally. So there's so much work from a workforce perspective, and I think you're right to ask for something to return to this committee where we can describe in more detail the plethora of work around how we recruit, how we retain, how we introduce new roles, what we hope the impact will be, etc. So I'm more than happy with Kirsty to come back and help share some of that information. But I think it's multifactorial, it's complicated, and it's been further exacerbated by by the COVID pandemic. But I think some of the things that are being developed and introduced aren't necessarily being described or communicated in a way that patients feel that actually these are real positive changes. And there is the balance, isn't there, between being able to see somebody same day or within sort of 2 days versus the continuity of care of seeing somebody that you may wish to see as a preferred professional. And again, there's lots of things there around balancing that. You know, the introduction of care navigation at that front end of GP surgery, so that the receptionist going through a series of questions to try to get you first time to the right person isn't around somebody being nosy. It's not around somebody trying to prevent you getting somewhere. It's around somebody trying to navigate you to the best place, you know, the first time. But again, unless we describe these things in the right way, with the right rationale, the right explanation, they don't land in the way that is intended. And I think one of the benefits of having a GP confederation in the city now is that for the last 2 years, we've been able to bring together GP practices. So, you know, currently we've got 94 different individual private businesses that deliver general practice care in the city. And for the, like I say, over the last 2 years, we've been increasingly working with those 94 practices in their 19 PCNs to say, how can we bring you together? How can we share good practice? How can we agree things so there's some consistency across the city? And how can we do that in the context of the primary care network being at the centre of the local care partnership, so that they are working with wider partners to understand the impact on health of things like housing and employment, so that there's a holistic view to how GPs operate in the city. All of this stuff takes time, and all of this stuff obviously has been significantly impacted by the pandemic, in which during that time GPs have, through their national contract, been directed how to work. So they, you know, not seeing people face to face unless it's absolutely clinically necessary was a national direction at the height of the pandemic, as is the national direction now to start to increase where it's clinically safe, an element of patients being able to choose to be seen face to face. But that's still against a backdrop of we are still in a pandemic, and we are still seeing absolutely required measures across our NHS services around, you know, pre-screening, face-to-face only where it's clinically necessary, in order that we protect the workforce and ensure that practices are resilient. So like I said, there's a number of factors here, but I think the work of the GP Confed in partnership with the CCG means that we are in a place where we can work together with those practices in their PCNs in the context of the local care partnership, and now what will be in the context of the provider work linking to the integrated care system. So like I say, I'm more than happy to come back at some other point and describe some of that work in more detail.
Thank you very much, Dana.
I don't know if you had any specific question, or if you were happy just for those general.
I can see Councillor Dowson's got her hands up. Yes, Councillor.
Sorry, yes, me again. Social prescribing. Do we have any statistics on how social prescribing works, how popular it is, how successful it is, how many referrals are made from the doctor, or are referrals made from the receptionist? I think it's a really important area of work, but I suspect that we're not getting all the referrals that should go through a social prescriber. And is there a consistency across the city with regard? I did ask in the text at one meeting, you know, for some details on social prescribing. Does every GP's practice have a social prescriber? Because often when you see your GP, it isn't necessarily a physical issue, or it might be a physical issue that would be helped by exercise or helped by a yoga class or something that we fund often as counsellors. You know, we've just funded a pain clinic in our area linked to the GP's practice. But I think we do need to know who's getting referred, and is the referral from the doctor or somebody else?
Very good question. Kirsty or Gaynor, who's going to answer that, please?
I'm happy to pick that up. So Councillor Dowson, just in response to that specific question, does every GP practice have social prescribing? Yes. So there is a citywide service in place. The contract, I think, changed to the current provider, I think it's probably about 18 months ago now, in which that contract brought together a citywide provision from what had been a number of different social prescribing providers. And again, that linked to some national changes around the requirement for social prescribing. So it's a citywide service now. It's a service that's delivered through a partnership of those previous providers. And there is provision into every PCN, into every practice for social prescribing. Over and above the citywide contract, there is the ability through the primary care network enhanced role scheme that we've mentioned before, which is the scheme whereby we've seen the growth of different professionals in primary care. There is the opportunity through that scheme as well for practices to add to the citywide provision and have people who are in very similar roles to the citywide social prescribers, so that there can be increased capacity at practice level. There is a citywide social prescribing steering group that will receive the sorts of performance information that you're interested in, Councillor Dowson, in terms of numbers of referrals, sources of referral, outcomes for those referrals, and quality metrics as well. So again, I'm sure that through Angela, if that's something that you feel you would want more detail of at a future meeting, again, there's absolutely the people and the mechanism for those performance indicators.
If you would, I'd be really grateful, Gaynor, because it is of concern to me that I've got people who I perceive would be best served by helping the community through social prescribing to local voluntary sector organisations who aren't getting those referrals, who aren't even being told there is a social prescriber in the practice. So those statistics I will find very useful. Get me as many as you can and I will pore over them.
Thank you very much, Councillor Dowson. Right, we need to move on to our next agenda. To all the councillors who have got their cameras switched off, can you give me a thumbs up? Virtual one, so that I know you're there. No, the ones who have their cameras on, you're good, no problem. The ones who have theirs switched off, you've got your camera, can I say a thumbs up from all of you? You can give me a virtual one. Councillor Cunningham, are you there? Councillor Latte, are you there? Councillor Kidger, are you there? That's very good. Look at all of them doing well, so thank you. Right, moving on to agenda 5, it's the restart and prioritisation plans for delivery of the NHS programme. I believe we have officers who will need to introduce themselves. Now, the report from the Director of Public Health focuses on the impact of COVID-19 on NHS Health Check programme delivery throughout 2020 and 2021, and the steps being taken to plan for the restart and recovery of this programme. Gaynor, I believe you're going to be staying on this one as well, so thank you for staying on. I will now like to introduce Lucy and Carl. Could you kindly introduce yourselves, please?
Thank you, Councillor. Lucy Jackson, Chief Officer in Adults and Health and Consultant in Public Health at Leeds City Council.
Thanks for coming. Carl?
Hi, Carl Mackey, Head of Public Health for Long-Term Conditions. Thank you.
Thank you very much. I'll now ask Councillor Arif to make a brief introduction, please.
Thank you, Chair. Just forgive me, my internet's a tad bit weak. I can't, everybody else is frozen other than the person who's talking. So I'm trying my best to keep but I can hear everything, which is good. Chair, this paper provides an overview and an update on the NHS Health Check programme within Leeds, including the impact of the COVID pandemic and on delivery and the planning being undertaken to support a programme of recovery. The NHS Health Check is one of the nationally public health mandated services for local authorities within the 2013 Health and Social Care Act. It is for adults in England aged 40 to 74 who do not have any cardiovascular disease. It's designed to identify early signs of stroke, kidney disease, heart disease, type 2 diabetes or dementia, and either prevent people from developing them through a healthy living support or ensure people have effective support and medication to manage any medical conditions identified. The NHS Health Check is currently delivered through GPs in primary care, and the present provider is the Leeds GP Confederation. Obviously, we've got Gaynor in attendance today. The paper highlights how the pandemic has significantly impacted on the NHS Health Check delivery. For example, only 18% of the total NHS Health Checks delivered in 2019-20 were delivered in 2020 and 21. That's effectively meaning significantly fewer people have been identified as high risk of developing cardiovascular disease. Therefore, it is imperative that the restart and the recovery of NHS health checks, including a programme of catch-up, is implemented as soon as possible to mitigate any increase in cardiovascular disease risks at both an individual and a population level, as well as avoiding the exacerbation of existing health inequalities. This obviously is in the context of reduced staff capacity in primary care, with the prioritisation of the COVID-19 vaccination programme and other primary care restart priorities. A decision to extend the NHS Health Check contract with the current provider, Leeds GP Confederation, from the 31st of March 2022, invoking a 2-year extension, was recently approved. The rationale for this was to help avoid disruption and ensure a focus on restart and recovery. Public Health has been working with the GP Confederation to plan for restarting and catching up in 2021-22, working alongside the Leeds CCG colleagues who are co-commissioners of primary care. An options paper has been produced to inform these conversations, as you can see in the paper. In addition, the Leeds GP Confederation have engaged with GP practices to gauge capacity to deliver NHS health checks now and over the next 6 to 12 months. This will inform a detailed restart and recovery plan currently being developed by the GP Confederation. Chair, I will now hand over to Gaynor from Leeds GP Confederation, who will present an overview of the areas of focus that will be included in the restart and recovery plan to outline the next steps. Thank you.
Okay, thank you very much, Councillor Arif. I was just before Gaynor comes in, could I ask if Victoria will want to make any brief comment? Victoria?
Thank you, Chair. No comments from me. Thank you.
Thank you very much. Over to you, Gaynor.
Thanks, Chair, and thanks, Councillor Arif, for that introduction. I'm conscious that you've had in your pack 2 detailed papers. So what I wanted to do, if that's okay, is just share a brief set of slides so I can pick out the salient points to give hopefully to provide assurance then to the group that we're taking this restart as seriously as we need to be doing. So just bear with me while I share my screen. Has my screen shared? Thank you. So as we've heard, the aim of the NHS Health Check there is to help prevent heart disease, stroke, diabetes, kidney disease, and certain types of dementia. As Councillor Arif, talked about in her introduction, it's something there which, it is a real preventative focus and really provides the opportunity to reduce and manage risk, and really nudges people with lifestyle behaviour change. So this table was included in the paper, but it was just to give some context that pre-pandemic we were doing really well across Leeds with uptake, and we had one of the highest uptakes in the country, really, or certainly across the core cities, where we were seeing that our uptake in Leeds was 10% higher than the national average. So, great to look back to see where the baseline that we had pre-pandemic, but actually we need to be well aware now of the impact of COVID, which as we've heard in the introduction, in 2019-2020, 43% of the eligible population received an NHS Health Check, which I say, if we look at that on the data on the previous table, did put us, well in advance of some of the other comparator places. But in 2020-21 so far, we've only got 7.6% of the eligible population having received an NHS Health Check. And I think we've heard lots already around the context within which general practices are working or have been working over the last 18 months, whilst we've been in the middle of the COVID pandemic. And in fact, in the first wave of the pandemic, when instructions were coming out nationally around what was seen as the priority services to offer, NHS Health Checks was one of those things that was seen as a lesser priority for GP practices to be offering at the height of the pandemic. So we need to now think about, as we've said, the real vital work to restart. And again, as Councillor Arif said, as the contract holder, the GP Confed, we are working really closely with our Leeds City Council colleagues on really fleshing out the real detail behind this restart plan, which has got 4 elements to it, which is some real engagement at PCN level to understand what the data is saying around the number of priority patients in that PCN, how many health checks have been undertaken, what's the current situation capacity of the practices within that PCN, and how can we really help the PCNs to have what we call a forensic spotlight, so that they really drill down into the data to understand who's eligible, who's not had a health check, and how they should be using their available capacity to really focus and offer NHS health checks. But we know that won't be the same level of capacity and consistency right across our practices across the 19 PCNs. So there's other overlaying elements that we want to do to the restart plan, which is to offer extra clinics via our extended access service. So the Leeds GP Confed currently holds a citywide contract to provide extended access, which is access to appointments during the evening and the weekend. So again, we really want to look at that profile of appointments and balancing the need to have some of that extended access link into same day demand, but also having some of those appointments offering capacity for NHS health checks. So again, we'll work with each PCN to say, this is what you might be able to do through your practices. How can we then build on that by offering additional capacity within your extended access hubs? And then over and above that, the third element will be, can we actually recruit a sessional team to almost do some waiting list work, so that again, looking at that data, we can say, where are the priority groups? Who's missed an NHS health check in the last 12 months, and how can we really reach out and focus on reaching those individuals? And then we can offer to those individuals, like I say, something that could be at their practice level, it could be within that extended access service, or it could be something, like I say, that could be more tailored, where we could have certain clinics at certain times in certain locations and use this new sessional workforce to increase the capacity and the offer for NHS health checks. And we're working with an organisation to understand how we might be able to do that, and like I say, add that additional capacity in. And then I think there's a fourth element to this that we're exploring, is how we can use digital and other kind of virtual tools really to both publicise and promote the uptake of the NHS health check, as well as maybe using some of that digital way of working to complete an element of the health check. So again, we're able to reach more people. If I can just share this slide, which I appreciate, sorry, is quite busy, but I do hope you'll be able to see it on screen, because what I wanted to share with you is that forensic spotlight, or that 4 elements of the plan that I've described to you there. We've actually had real life experience of using that approach over the last year, so at the height of the pandemic, where we've been working with the 19 PCNs to look at the requirement to achieve a 67% uptake within each PCN of 67% of people who are eligible for the annual learning disability health check. And because we've had a real, like I say, forensic spotlight, as we call it, a real focus to understanding the data, drilling down at practice level, drilling down at individual level, working across the 19 PCNs to share good practice and share capacity. You can see at that red line, which was the target that NHS England set through the National GP contract for 67% of those eligible having had their NHS health check. You can see with the blue bars where previous performance was at across each PCN, which are listed across the bottom. So in March 2020, the blue line. Now you can see, for example, in the middle, we'd got one PCN, which is LSMP and the light. In 2020, their achievement was only 13.3% of their eligible learning disability population having received an NHS health check. through the work that we've done, you can now see that in March 2021, that PCN has now achieved a 75% uptake. There'll be various numbers behind the percentage, but I think what this graph illustrates is the impact that we're hoping to have through this a really clear four-pronged approach and real clear focus to working with our PCNs on the restart of the NHS Health Check. So our current projections is that we hope to return during 2022-23. We hope, with everything that we've heard around the context and the reset of other services and the backlog of other like long-term condition checks and face-to-face access that concerns have been raised earlier on in the meeting, we hope to return to pre-pandemic levels of activity during 2022-23. We want to, through the work that we've described, like I say, through that four-stage approach, bring immediate focus to those who are most likely to benefit. So we'll use the data, like I say, to drill down and identify where the individuals and the cohorts are that we need to focus on. And we will be targeting those high-risk individuals who've missed their NHS Health Check in the last 12 months. So that's the work that we're doing as a ComFed, as a current contract holder, with our public health and commissioning colleagues in the council and in the CCG. There is a but to this, which unfortunately I do need to raise, which again, councillors and colleagues may be aware of, is that we are in the middle of a global shortage of blood bottles, and nationally that is now leading to direction into the NHS that across all elements of the NHS, so acute care, primary care, mental health care, that no non-urgent blood samples should be taken and progressed at the moment because of the need to protect the supply of blood bottles. So this will have some impact on our restart plan, because as part of the NHS Health Check, there are routine blood samples taken. So we are looking to see, to try and understand the intelligence of how long this shortage may last for, so that we can then recalibrate our projections. And we are also looking at whether there's other technology that we can introduce, such as point of care testing, which means that a blood sample can be taken, doesn't require to be put into a bottle and sent to a lab, but it allows us to, at that point of care and interaction with the patient, it allows us to check things like cholesterol and blood sugar levels. So again, there's some elements of the NHS Health Check that we can take forward in a different way. So again, just to assure councillors and colleagues that we are looking at to mitigate the impact of the global shortage of blood bottles. I'm going to pause there, like I say, just picking out some of the brief points that you've had in the two papers, and then I'll pause for questions.
Okay, thank you very much for that, Gaynor. It's actually refreshing to see some positive resolutions to some of the setbacks we've had over the pandemic. So I will now call on Councillor Dowson. First question.
Right, sorry. We talk about this quite a lot because prevention, as I've already said, is better than cure, and this is one of the major things, especially with statins and so on, and cholesterol. It is important, and some of the drugs you give for cholesterol you can't actually give if you've got liver problems. So it's quite important sometimes that you get those two tests done together. But totally appreciate that the cholesterol one can be done independently. So how many doctor surgeries will have this ability to do the point of care testing of certain elements of that? And speaking as one of the 40,000 that haven't been invited for my tests yet, and bearing in mind what you've said about the blood bottles, what is the projection going forward as to, and obviously it's how long is a piece of string, so I do realise this is going to be a guesstimate, absolutely, but you said 22-23, and you've got more people who come into that category during, well, from now till 23. So are we ever going to catch up with this, or are we always going to be running behind ourselves for many years?
I think in relation to the impact of the shortage of blood bottles, I think you're right, Councillor Dowson, in terms of it's how long is a piece of string. But like I said, what we are doing is trying to understand how we can mitigate that. Point of care testing, like I say, for cholesterol and blood sugar would be one way of doing that. That won't be available in every surgery. because the kit for point of care testing isn't necessarily available in every surgery. But that's where we'll look to use that technology, if you like, within, for example, like the extended access service, or within specific clinics where we can make sure that that point of care testing is available and people are invited for the health check to take advantage of that testing. If the blood bottle shortage goes on and on and on, which again, like I say, we're not really sure, we're relying on kind of international and national supplies, then it would be more prudent that we did look at whether there is the need to do that point of care testing in every surgery, and what that might look like, and how might we be able to do that. But at the moment, the national message is very clear that non-urgent bloods using those blood bottles shouldn't take place. And so once we understand how long that may be in place, we can then understand, like I said, the next steps. But we will, like I say, make point of care testing available in certain locations. I think there's a catch up to do, as you say, in terms of we need to invite those people that have missed their NHS Health Check. And I think what we want to do is, by the point we get to 2022-23, so sort of April of next year, have done as much of that catch up as we possibly can do, so that we're then starting again from a baseline. The ability to do that catch up won't be just within normal GP surgeries, because as we've heard, there isn't the capacity to do that alongside the need to catch up and restart everything else. And I also think just here it's maybe worth me commenting on the impact, not just of the pandemic in terms of all of the things that we've talked about, but the requirement as part of the pandemic for GP practices to vaccinate. So, we hit a milestone several weeks ago now of having over 1 million vaccines being given in our city, which is absolutely fantastic. But I think it's worth saying, just by way of context, that 3/4 of those, so over 700,000 of those vaccines, have been given in GP practices. So as well as running normal services, trying to run normal services and trying to respond to all of the requirements of the pandemic, GPs have been really heavily involved, and their teams have been really heavily involved in giving significant numbers of COVID vaccinations. That's not going away. So we know that we're about to embark, as soon as it's finalised and announced, we're about to embark on a booster programme. We're about to embark on a programme of people who are very immunosuppressed having a third dose. We're waiting for whether there will be announcements around 12 to 15-year-old young people, and whether they will be called for vaccinations, alongside the evergreen offer of everybody that is being eligible in the cohort so far, being able to access a vaccine should they change their mind and become less hesitant than they were before. So I know that's slight off a tangent, but I just think it's worth adding that into the context of everything else. So just coming back to the catch up for NHS health checks, we will have to create additional capacity that sits outside of practices to do the catch up, which is where we need to use the extended access service. And again, balance that between, if we used all of that capacity to do NHS health checks, we'd then be creating an issue around same day access, or access to other services that people can book in on an evening or a weekend. So there's a balance, as well as, like I say, talking to potentially another provider as whether we can work in partnership with them to put on some additional sessions to do some catch-ups, focusing on the people who are most at risk first. So people who smoke, people who are overweight, and people who live in kind of our most deprived communities.
Okay, thank you very much, Gaynor. Councillor Cunningham.
Thanks, Chair. Thanks, Gaynor. My question is really around who performs the NHS health checks. Is it always a GP? And also then linking into just asking a bit more about the kind of the advertising of the importance of those sessions, because I don't think that I've seen very much around, that tells me if I get this, then it's an important thing to do. Thank you.
Yeah, thanks, Councillor Cunningham. It's not a GP that performs the NHS Health Check, so it's a professional, but it's not a GP. So it would be people that are trained in terms of delivering the NHS Health Check. So that could be a practice nurse, it could be a healthcare assistant, it could be a care coordinator, and what so people would have the training to undertake the different elements of the health check. And what we also build into that training is the better conversation approach and the what matters to me approach, so that the health check is taken, it is offered in the spirit of it being a partnership conversation between the practitioner and the person. So it's very much, like I say, what matters to you. Like I say, how do we have a better conversation? So it's a coaching, it's an empowering conversation, as opposed to it being a kind of medical or a medicalised intervention. And I think you're right in terms of the publicity. And I think we have discussed, I mean, Lucy's nodding, we've certainly discussed in the NHS Health Check contract meetings the need to publicise and the timing of publicising, in terms of, again, we need to make sure that we've got that additional capacity ready to go. We can then advertise and publicise, because if we do the advertising and the publicising first, then what we'll do is we'll cause a load of traffic to GP surgeries, and then we'll get the GP surgery saying we're not offering them at the minute, we haven't got capacity to do it, and then we'll get people who feel very frustrated that they've been offered something that then they can't have. So we need to understand, where is that capacity, how can we make available then, actually your health check is really important, this is why you should have it, and this is where you can have it. And so we'll do all of that together, but certainly the comms and the publicising was something that we've absolutely touched on.
Okay. Can I just come back briefly then? If it is other healthcare professionals, could these sessions not be delivered within pre-existing groups, for example, in community centres as a kind of wellbeing cafe and things like that, rather than people having to go to the practices to access these?
Yeah, I think that's a really, really good point, and I think we'll have more flexibility like that if we, like I say, if we're working with working alongside another provider to create some of that capacity. I think because traditionally NHS health checks have been well, I think two things. I think that the contract is with the GP Confed, and then that means it's delivered through GP practices. The advantage of that is you've got access to the registered list, so you can easily identify those people who are most at risk and who would most likely benefit from an NHS health check, because we've got the registered list. So the potential disadvantage of doing that is that you've got the workforce attached to general practice, and the workforce that attached to general practice are the ones that are used to working in surgeries, in buildings. So I think this is where the work that we do with practices in their PCNs with wider partners in terms of the local care partnership, where there's some benefits to understanding actually for a GP practice to let their healthcare assistant go to a community cafe and spend an afternoon there, they're more likely to get a better uptake and more likely for people to have a better experience and a better outcome. There's benefits to that outweigh the disadvantage of not having your healthcare assistant in your building for that afternoon. So again, it's just different ways of working. There have been sort of trials, I think, in other areas and also in Leeds of offering the health check through things like supermarkets, but the experience of that is there's not often really great uptake, and that if it is something that's branded as NHS and offered through the NHS, there is a higher uptake. And again, I think going back to that table of where pre-pandemic, where we were seeing significantly higher rates than other comparable places, is because we have stayed sort of faithful to that model of using the NHS brand. And people, people liking that and responding to that. But like with everything, I think there's a balance, and I think the restart plan will give us an opportunity, I think, to test out delivery in different places linked to the heart of communities more.
Thank you.
Okay, Dana, thank you very much. Dr. Beale, I'll come back to you, Councillor Dowson. I just want everyone else to have a go, and I'll come back to you. You've got your hands up still.
Sorry, I shall take it down. I don't want to come in. Apologies.
Thank you, Chair. I'm just trying to understand how it actually works. I know that the rules are set nationally, but it's for people between the age of 40 and 74 who don't have one of a number of chronic conditions. So how does that work? Does the computer go through the electronic records, delete anyone who's got one of those conditions, and then put the others down for being called for a health check? Secondly, I accept entirely that there are groups which need to be identified as priorities. But my question is, I know you won't believe this, Chair, but I am actually over 40. And like Councillor Dowson, I've never been invited for a health check. In fact, the only one I had was when I phoned the practice and said, I believe I'm entitled to one. And they said, oh, well, yeah, if you want to, you can come in and have it. So my question is, are all practices supposed to offer their patients health checks if they fit the criteria? The third question is, why does it end at 74? Councillor Dowson's dad might well benefit from a periodic health check. So why does it finish at the age of 74? And lastly, on page 30, and it was the table which Gaynor showed us in her presentation, there are 5 columns, and I understand 3 of them, but I don't understand column 2 and 3. In particular, I don't understand why the figures for England and for Yorkshire and the Humber are identical. Maybe it's just me being thick, but could that be explained to an ignoramus like me, please?
I'll come back on a couple of those points, Dr. Beale, if I can. So I think in terms of the sort of simple question, should every GP practice be offering? Yes, it is the question to that. And I think that with the approach that we've agreed as part of the reset plan, where we're really going to drill down into the data for each practice in each PCN, it will give us the opportunity, like we did with the learning disability annual health checks, to understand each practice's position and then the position for each PCN. So I think with this approach that we've agreed, we will have, like I say, much more focused and targeted discussions where we see evidence of a practice that's not inviting their eligible population. And like I say, if they're in a position where they feel they don't have the current capacity to do it, then we can offer those patients in that practice a different way of accessing the NHS Health Check. What it means to that practice is that then they don't generate the income. So it's like the NHS Health Check to GP practices is like lots of elements of the GP contract. It's an item of service fee. So if they don't perform an NHS Health Check, they don't receive the income for it. So there is some financial incentive to practices, but that financial incentive, like I say, needs to be offset with, do they have the capacity to do it and the capacity to do it well? And if they don't, like I say, we'll make alternative provision. I think going back to the how are people identified? So yes, there are searches within the data quality kind of sphere that are run through the GP registered list, which is why there's the advantage to having this in primary care, because those searches can be run very quickly once they're all set up by the technical wizards, where it does identify this is your eligible population. And what we've agreed as part of this contract with public health colleagues is that there's a sort of a targeted universalism to it. So everybody that's over the age and in those age brackets is entitled and eligible to have a health check. But we also identify that there are people within that cohort that can benefit from it more. So as I said before, people who smoke, people who are overweight, or people that might be facing some inequality in some way. So we would target those people as a kind of, like I say, targeted universal offer. And I think probably the cutoff at 74 is probably somebody somewhere nationally having a kind of a thought that maybe as you get older, it's more likely that you will have a long-term condition. There will be a minority of the population who are in that very lucky bracket of growing older without developing long-term conditions, who you then could argue should still benefit from, who would still benefit from an NHS Health Check. But they'll probably be in the minority that as the older we get, I'm over 40 as well, just to give, the older we get, the more likely it is that we're going to pick up other long-term conditions and things. So I think that's probably why it's age 74 as the top end.
Okay, thank you.
And the table, Chair, that I don't understand, maybe Dana can send me.
Yeah, I think Lucy's put a comment in saying that we're apologising that there's a typo in the table. So apologies that it went into the paper, and apologies that I reproduced it on a slide. We will send through the proper figures, but thank you, Dr. Beale, for picking that out.
Okay, thanks.
We will resend another copy, Dr. Beale, and we'll send it out to yourself. Okay, Councillor Arif.
Thank you, Chair. Just following on from Councillor Cunningham's point, and I absolutely agree. I think we need to also look at how we go about being in our communities. As the vaccination programme has proved, you know, people like to be to go to their trusted local venues, and I think that's perhaps learning we ought to take and slightly think outside of the box. Can we tag it along to another wellbeing session that's happening in the local community? Maybe raise awareness there. The other point I wanted to make was about communication. One of the priority groups are individuals that are BAME. Are we looking at how we're communicating? Do we have, when we're sending the letter out, is it or a phone call? Is it perhaps there might be individuals I know who may not understand English? How are we communicating to them? Is that something that we're aware of as well? So just a couple of those things that I wanted to bring up, Chair. Thank you.
Yeah, I don't think we've probably done well. I mean, like I say, everything's kind of, we're talking now pre-pandemic, post-pandemic, or during pandemic, aren't we? So I think that as we restart post-pandemic, I think we'll look back at what we did pre-pandemic around comms and engagement, and maybe overlay that with what we have learned during the pandemic, which is how we reach individuals and community of interests in different way, including say people where we've got ethnic diverse communities and people, you know, citizens of a BAME background, because we've learned lots through the COVID vaccination programme about how to engage, how to communicate, how to make sure that messages are sent in a way that they can be received and understood. So again, I think as part of what Lucy, as the you know, sort of lead public health commissioner on Victoria's behalf, will require of us, of our reset, is to really reflect all of that in the comms plan, so that it's not just well, we're just going to do what we did before, which maybe what we've learned now is we can do better. And again, going back to the forensic spotlight and the example of the learning disability annual health check, I think we can do better going forward. All of that balanced with, we've got to be realistic about what the capacity is out there.
Thank you very much, Gaynor. Councillor Latty.
Thank you, Madam Chairman. Just a couple of quick questions. One, this business of not everybody taking up the offer, or a lot of people not taking up the offer, how are people invited? I mean, in my experience, it's just been a text saying, please ring the surgery and make an appointment for a health check. And the explanation came after you'd rung the surgery. I just wonder how we're doing this. And the other thing is, do we have a sort of a success rate or failure rate or whatever you call it, but people who were found to be in danger of one of the problems that we're trying to eradicate?
Yeah, thank you. And again, I think it will probably vary practice to practice in terms of that initial invite. Lots of practices will reply on that sort of initial text out message to say you're eligible for a health check. You know, please contact the practice. And like I say, that works for some individuals in some communities, but doesn't work for all. So again, I think that look PCN by PCN, practice by practice. What's your normal mode of operandi in terms of NHS health checks? What did you do pre-pandemic? What have you learned? What can we do now? And how might we be able to do that, you know, differently, sort of using what we've learned. So we'll do that, because so we had the same issues with the learning disability annual health check, which was leading, like I said, to some really poor uptake in some places. Going over that and being really consistent and really being clear around what's the best practice, what's the best way of doing it. And we certainly know, again, from a COVID vaccination perspective, that in certain communities and to certain demographics, just sending out a text message or having something, say, on a practice website that says actually you can self-refer or you can book yourself in, doesn't reach who we need it to reach. And I think so we need to do more work on that. And I think in terms of the data around what have been the outcomes to NHS health checks, again, as part of the conversations that we're having around a performance or a set of indicators around performance and outcomes, that will be something that we will look to build in and hopefully be able to bring back to this group should you wish it, in terms of these are the number of people that have been screened, these are the number of people where there's been issues found, these are the number of people who have then gone on to have referrals to other services or start medication or whatever. We'll look to see how much of that data we can collect and present back.
Thank you. And just quickly, now that we've got this wonderful new future for the NHS and for local authorities moving forward, perhaps there might be the opportunity to get sort of parity across the whole piece, that everybody does it the same way, or invites people in a more alluring way than just coming for a health check, Yeah.
Yeah, I think there's absolutely opportunity to do that, Councillor Latte. Often the challenge that we work with, I think sort of mentioned before, that GPs are all individual businesses, so there's different ways that we can require GP practices to do things. One is through the contractual route, so either it's in the national contract or it's something that's locally commissioned, so therefore there's an incentive or a contractual requirement for them to do something in the same way. The other way is influence, and again I think that's where the GP Confed comes in, where we can influence by the way of saying, this is what's happening over here, and this is really good practice, and this has had this impact, and this is really easy to do it like this. So why don't all of our 94 practices in our 19 PCNs start to do it this way? And we can then change behaviour, change the way that things are delivered through that influence and through that kind of collective will, which, like I say, is something that we haven't had before. Where the mechanisms have been, either it's something that comes through a contractual route or it's something that's locally incentivised by the CCG. But that collective will now, the GPs working together, understanding what they can do together and how they might share good practice and be consistent, is something that we can really help to influence. But the bottom line is they are all individual businesses and can choose to do, within the terms of their contracts, they can choose to do things in different ways, should they so wish.
Right. So which of the methods are you going to use? Sorry, Councillor Latte. Which of the methods are you going to use, Gaynor? What are you all thinking in terms of getting them on board, the 94 GP practices, with what you've just said?
Yeah, so I think there's a contract. So there's a contractual route, so and there's the opportunity for them to gain income through an item of service fee. So if they wish to participate in the delivery of that contract and receive the item of service fee, there's a schedule that says this is how the health check must be done. So we've got some consistency there, and then the other approach will be to say, with all the learning that we've had, like I say, during the pandemic and with the learning disability health checks, will be to say, if we present the data back to practices in their PCNs, it says, actually, this is the size of your eligible population. And we do some of that work on their behalf at the Confed level, so it makes it easier for them. We say, we present you with the data which says, this is your eligible population. This is how many people have had a health check. These are where we think that your more targeted communities or individuals are. How can we help you reach them? Is that something that you can do within your surgeries, or is this something that you want to do within extended access or with some additional clinics that we can put on for the NHS Health Check? And then what we'll do is understand how best to communicate with people. What's worked? Is it a text message? Is it a letter? Is it a phone call? And how do we create that capacity to do that, and how do we understand the impact of each of those things that we've done? So if we suddenly decide actually it's all going to be a phone call, is the capacity and the effort of phoning people does that result in the increase uptake, and therefore there's a proven benefit to that way of working. So that's how we'll approach it.
Okay, thank you. Councillor Latty.
Just good to know that you're thinking about it. Thank you.
Thank you. Victoria.
Thank you, Chair. It was just a comment, and Lucy and Carl and Gaynor may want to say a bit more about this, but it was a comment around the conversation about why under 75 and how does it line up with the other health checks. And I think it's important because for people might remember that we had a target around reducing preventable death, and the way that was defined was deaths under 75, because we already had an over 75s annual health check. Now, from previous conversations in this meeting, we know that actually that isn't happening as it should be at the moment, but at the time there was a statutory annual over 75 health check, and there was health checks for people in particular groups, such as people with learning disabilities, as Gaynor has mentioned, people with severe and enduring mental illness. So this was seen to fill a gap and be the preventative sort of general population health check that was added to the rest. And what's happened in the meantime is some of that rest has fallen away. And what's also happened with this is that since it was set up, the budget for this health check has been reduced. You know, we've had to make savings through public health cuts for how we deliver and prioritise within this health check. So I think it's just important kind of context for why we can't do everybody. We want to target the people who would benefit the most. And I'd just also like to, in terms of the work that we do with Gaynor and colleagues, we know right through COVID and before that engaging GPs and primary care in prevention work with communities is good for the city. It's central to how we work, and reflects some of the previous conversations we had earlier around, how can we really build this into what GPs do and support the GP workforce of the future. So there's all sorts of reasons for why we have the model in Leeds, and the credibility and the respect of GPs too. But I just wanted to kind of share that history really of how this fitted in. This was meant to be the extra bit to what went before. Much of that's fallen away with pandemic. We really want to build this back up, but there's limited resource, and as Gaynor said, there's limited capacity and other competing demands. But we do want to do it in the best possible way to reach the people who would most benefit, because we know that sadly, the number of deaths that we've had through pandemic really reflects the level of health, general health in the population, those underlying conditions that make people more susceptible to impact of COVID or, whatever comes next. So it's a real opportunity to really work through this backlog and use this platform to address these underlying health needs. So yeah, just to add that, Chair, thank you.
Thank you very much, Victoria. Councillor Jackson.
Sorry, was that me? Yes, about the health checks, I wonder if we can't do blood tests within the 20 minutes, maybe we could ask a question about a person's mental health, because I think that's one of the biggest issues that COVID has affected, the pandemic has affected people. And I think if we can use that as a means to get to understand some women who've suffered domestic violence or controlling behaviour and things like that, which wouldn't perhaps come up in other formats, and maybe the simple referral to CBT or social prescriber might be an option. But I know these are competing demands. But I think in terms of preventative medicine and helping people in the community, it might be a good question to ask.
Okay, thank you. Lucy, do you want to come in there?
Thank you, Chair. I just wanted to, and I think it is in the paper, but just to mention that there is a national NHS England, Public Health England review of the NHS Health Check, and that what is delivered is nationally prescribed. So they are looking at this. They're looking at whether the age should be lowered. They weren't talking so much about the age being higher, but they were looking at whether the age should be lowered, and about whether other conditions should be put into this too. So we can do things like we have done locally, very much always targeting at those most at risk, and working locally with communities, but it is a nationally mandated, and there might be changes to come.
Yeah.
Thank you.
Thank you very much. I mean, if we look at how we went about the vaccines, especially locally, Victoria, I mean, I would say for Leeds, you know, you did a fantastic job with that, especially with the flexibility. You know, it started very stringent at the beginning, and then gradually, you know, there was more flexibility to it. So I think if we can also work and use that kind of flexibility in terms of this health check and meeting the demands, especially of our older people. Councillor Jenkins, what will be interesting to hear from you? You're the older person's champion, and I believe it's Older People's Week from next week as well. So I come from a culture where we do not mess with our older people at all. You know, they're gold dust to us. So it's the same thing. They really, really need that care. So it will be interesting to hear from that cohort of people, especially with response to GP surgeries. One good thing that has also come out of the pandemic with older people, their computer skills is amazing, you know. So obviously a lot of them who were not able to get through to surgeries on their own, I mean, a lot of them are beginning to do that. And still a good number of them are very hesitant as well in terms of telephone conversations with GP practices. So it will be nice as we're Gaynor working with yourselves and Kirsty, information that we're going to feed back to this group. With the older people, it will be very, very pertinent to get their voices as well with how they are being looked after, especially after the whole 18 months and what they're going through, especially with them not having access to seeing their doctors. It's just sad to hear that an older person, 95, has not seen a doctor in 3 years. That's just frightening. So Councillor Jenkins, please could you, if you don't mind, work with us as well so that we can hear the voices of older people as we work on this agenda.
Yeah, quite happy to.
Thank you. Has anyone got any comments on item 5? Any questions? Fantastic. Those that have their camera switched off, can you give me a virtual thumbs up if you've got no questions, or let me just see your faces? Fabulous. Councillor Cunningham, thumbs up. Excellent. Councillor Kidger? Where is she? She is there though. Fabulous. Right. I will hand over to Angela for the last agenda.
Thank you, Chair. So the last item relates to the board's forthcoming work schedule. So the latest version of the work schedule is set out in Appendix 1 for members' consideration. Just to say, I will work with the Chair to reflect on the board's discussions today in terms of scheduling in follow-up sessions where this has been agreed already, but members are invited at this stage to also make any other comments on the work schedule. So I'll pass back to you now, Chair. Thank you.
Okay, thank you very much. If nothing else, just to let you know that our next meeting will be the 5th of October. It's a Tuesday, and that's planned to be a face-to-face meeting. But if anything is different, we will let you know with good enough notice, if that's okay. Anybody else got anything else to say? Comment, questions? Remember, if anything comes to your mind that needs urgent attention, you do not need to wait till the next scrutiny meeting. Please pop an email through to myself or to Angela, and we would look into it. Anything else from anyone? To all our guests who have joined us today, thank you very much. Thank you for your input, your contribution, information, updates. We're truly grateful. Jane Dawson, what did you say? Oh, see you. Yeah, see you, Jane. Thank you very much. Anything else from anyone? Right, have a lovely afternoon, you all.